Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing an in-depth, evidence-based deep dive into cyclic vomiting syndrome, or CVS.
Exactly. We're focusing specifically on how we as hospitalists handle this in the acute inpatient setting. So diagnosis, stabilization, and thinking about those long-term management strategies too.
And we're drawing heavily on the latest guidelines, particularly from the American Gastroenterological Association and the American Neurogastroenterology and Motility Society.
Yeah, this is really essential stuff for us hospitalists. These patients, when they come in with an acute CVS episode, they are often incredibly sick.
They really are. They're landing in our emergency departments, getting admitted, and despite how severe it can be, it's still highly morbid and very frequently misdiagnosed.
That's the crux of it.
Yeah.
So our goal today is really to equip everyone listening to look beyond just, say, fixing the dehydration.
Right, beyond just the acute volume resuscitation.
And to recognize this underlying cyclic disorder much earlier.
Precisely, to see the path.
Okay, so let's start with the basics. How do we define CVS?
Well, the AGA definition is key here. It's not just vomiting. It's classified as a chronic disorder of gut-brain interaction.
Gut-brain interaction. That's important.
It really is. And the clinical hallmark, the thing you absolutely have to recognize, is the recurrent, highly stereotypic nature of these episodes.
Stereotypic meaning?
Meaning they're predictable for that individual patient. The same pattern of intense nausea, vomiting, retching, and crucially, these episodes are separated by symptom-free intervals. Weeks, sometimes months, where they feel completely normal.
Right, and missing that pattern has real consequences, doesn't it?
Huge sequelae. We see high morbidity, those frequent costly ED visits we mentioned, and a real risk of long-term disability if it's not managed properly.
And you mentioned misdiagnosis earlier. What does it typically get confused with?
Oh, commonly. Simple acute gastroenteritis is a big one. Or maybe a primary headache disorder like migraine because of the symptom overlap.
And increasingly, cannabinoid hyperemesis syndrome, CHS.
Yes, absolutely. CHS is a major mimic we need to differentiate. So the hospital's challenge really is to pick up on that predictable stereotypic nature. Often the patient can tell you, this is exactly how my episodes start, this is how long they last. That pattern is what points strongly towards CVS.
Okay, let's talk epidemiology. Who gets this? What does the prevalence look like?
It's actually more common than many might think. Prevalence estimates in adults in the U.S. are somewhere between 0.3 to 2%.
And slightly higher in kids.
Yes, around 1.9 to 2.3% in children. There's also a clear sex difference. It's more common in females. The odds ratio is about 1.52.
Interesting. What about age of onset?
Well, the peak onset is often in school-age children, maybe 5 to 10 years old. But interestingly, the mean age for adults who present with established CVS is actually 36.7 years.
So we're seeing this across the lifespan. It's not just a pediatric condition that people grow out of necessarily.
Not at all. We have to be vigilant for it in adults, even middle-aged adults, where maybe the diagnosis was missed earlier or it gets mistaken for something structural.
You mentioned the migraine connection earlier. It's often called a migraine equivalent disorder. Tell us more about these core associations.
That link is undeniable. A strong personal history or even family history of migraine is a major risk factor. It's almost central to the CVS concept.
And the psychiatric comorbidities.
Equally important and strongly associated. Anxiety shows up with an odds ratio of 1.79. Depression is even higher, 3.14. And we see strong links with panic disorder too.
So when we see these patients, we need to think of the anxiety or depression not just as a reaction to being sick.
Exactly. It's not just secondary. It seems to be part of the underlying central dysregulation that drives CVS. These psychiatric elements can actually exacerbate the condition.
So given that, what are the typical triggers we should be asking about? The things that push someone from feeling okay into a full-blown episode?
The triggers are often quite predictable for the individual. Number one is usually intense psychological stress.
Makes sense given the HPA axis involvement we'll probably discuss.
Definitely. Also, intercurrent illness or infection, even just a common cold can set it off. Lack of adequate sleep is another big one. And for many women, menstruation is a known trigger.
These aren't just minor annoyances then, they're real physiological stressors.
Absolutely. They destabilize that baseline neurological equilibrium and kick off the whole emetic cascade.
Okay, let's dive deeper into the pathophysiology. Why does understanding the mechanisms, the genetic side, neurohormonal factors, the mitochondrial links, why is that important for how we treat it?
Because it explains why a simple antiemetic often isn't enough. It's complex, multifactorial disorder. At its core, you have this fundamental neuronal and autonomic dysregulation, meaning problems with central modulation in the brain, severe sympathetic nervous system overactivity, and basically the same kind of neuronal hyperexcitability you see in a classic migraine attack.
So the brain's vomiting center is just on edge, hypersensitive.
That's a good way to put it. It's hypersensitive to both internal and external signals. And then there's the mitochondrial piece.
Right, you mentioned that link.
It's particularly well recognized in pediatrics, but it's definitely relevant for adults too.
Yeah.
Basically, if mitochondria aren't working properly, cellular energy production is impaired.
And neurons need a lot of energy.
Exactly. They're incredibly energy dependent. So if energy production is shaky, it makes the central nervous system unstable. Then when a trigger hits stress, lack of sleep, whatever, the neurons can't maintain stability, they fire inappropriately, and boom, you get the cyclic of vomiting.
And we can't forget the stress axis, the HPA axis.
The hypothalamic pituitary adrenal axis. Yes, that's critical. We often see chronic hyperactivity in the system in CVS patients.
So stress activation directly triggers episodes.
It can, yes. The release of stress hormones can be a direct precipitant. There are even specific subtypes described, like the SADO subtype, which is linked with hypertension during attacks, really reflecting that massive neurohormonal surge.
Which reinforces why stress reduction isn't just, nice to have advice.
It's a physiological intervention, absolutely.
Sure. Okay, let's shift to diagnosis in the inpatient setting. We need to rely on the Rome 4 criteria, right? But that can be tough when the patient is actively vomiting and can barely talk.
It's very challenging. You often have to rely heavily on family members, caregivers, digging through old medical records, and then getting more history once the patient is somewhat stabilized.
So what are those core Rome 4 criteria?
Okay, there are 4 main points. First, 3 or more distinct episodes of vomiting within the past year.
Okay, discrete episodes.
Yes. Second, the episodes have to be stereotypic for that individual. Same timing, same duration, same general pattern each time.
Predictable for them.
Predictable for them. Third, they must be separated by weeks to months of basically normal health, symptom-free intervals.
Got it. And fourth,
you have to have reasonably excluded other structural or metabolic diseases that could explain the symptoms. Rule out the other possibilities.
And there's a nuance for adults, isn't there, about the symptom-free intervals?
Yes, that's important. While the classic definition emphasizes complete resolution between attacks, a good number of adults, actually, might have some mild lingering symptoms in between episodes, like low-grade nausea, maybe some dyspepsia.
So those low-level symptoms don't automatically rule out CVS in an adult?
Correct. As long as the main pattern of recurrent stereotypic attacks is clearly there, that mild interepisodic stuff doesn't necessarily invalidate the diagnosis.
Okay, let's walk through the typical clinical course, the 4 phases. Phase 1, the prodromal or pre-emetic phase. You said this is key for abortive therapy.
Absolutely crucial window, but it's often short. The median duration is only about an hour.
Wow, just an hour. What does it feel like for the patient?
Sounds terrifying, frankly. Intense crippling nausea, often accompanied by severe anxiety, panic attacks. Patients describe this profound sense of impending doom.
And physical symptoms, too.
Yes. Autonomic symptoms really ramp up here. Sweating, flushing, sometimes pallor, feeling really restless. Often a headache starts, maybe some diffuse abdominal pain.
And this is when we might see those self-soothing behaviors, like the hot showers.
Exactly. That compulsion to seek relief, often through external heat like hot showers or baths, is a big clue. It seems to help modulate that sympathetic overdrive somehow.
But the main clinical point for us...
Get the abortive therapy in now. During this prodrome, the chance of stopping the episode completely is much, much higher if you intervene before the full-blown vomiting starts.
Which brings us to phase 2. The vomiting, emetic, or acute phase. This is usually why they end up hospitalized.
This is the storm. Uncontrollable, relentless vomiting and retching. It can be multiple times an hour, leading to rapid dehydration, severe abdominal pain, and just profound lethargy.
And those migraine-like features often pop up here, too.
Very commonly. Because of that shared pathophysiology, you'll often see severe headache, photophobia sensitivity to light, phonophobia sensitivity to sound.
How disabled are patients during this phase?
Extremely. They're often described as being in a conscious coma. They can't communicate, they're totally focused on the vomiting. We really shouldn't underestimate how severe this phase is.
Then hopefully comes the recovery phase.
Right. This usually lasts about 1 to 2 days. The vomiting starts to subside. They can gradually, tentatively start tolerating oral intake. Again, usually clear electrolyte-rich fluids first.
But they're not just back to normal immediately.
No way. Recovery is exhausting, physically and mentally. Fatigue is universal. And there's often this lingering anxiety, this fear hanging over them about when the next attack might hit.
And finally, phase 4, the interepisodic phase.
For many, especially kids, they do return completely to their baseline health between episodes. But for that subset of adults we mentioned, they might have those persistent mild symptoms, the low-grade nausea, dyspepsia, mild abdominal pain.
But again, that doesn't rule out CVS if the main episodic pattern fits.
Correct.
Okay, now for the hospitalist seeing this acutely, priority number 1 has to be ruling out the dangerous mimics, right? The life-threatening stuff.
Absolutely. Targeted, efficient evaluation is key. Rule out the deadly structural and metabolic causes first.
What's top of the don't miss list?
Intracranial pathology. You have to be vigilant. Ask about headache, look for any new neurologic deficits, check carefully for papilledema on the fundoscopic exam. If any red flags are present, you need urgent brain imaging.
And metabolic problems.
Critical to consider, especially maybe in younger adults, or if the history suggests episodes are triggered by fasting or illness. You need to screen quickly, plasma ammonia, a comprehensive metabolic panel looking at electrolytes, anion gap, glucose, and urine organic acids. Missing an inborn error of metabolism can be catastrophic.
What about abdominal causes?
Also crucial to exclude. Things like intermittent intestinal obstruction, particularly malrotation with volvulus, can present episodically and look a lot like CVS. This needs imaging, usually an abdominal ultrasound or an upper GI series.
How aggressive should we be with imaging in general?
The guidelines recommend a targeted approach. You know, a one-time workup to rule out structural problems in a patient who's never been investigated is reasonable. But we need to avoid repeated reflexive scans or endoscopies every single time they present, unless there are new symptoms suggesting something different is going on.
Okay, let's talk about that big mimic. Cannabinoid hyperemesis syndrome, CHS, they can look similar. Patients might use cannabis. How do we tell them apart quickly?
History. That's really the key. Both can have recurrent vomiting. Both might use hot showers. But CHS requires that history of chronic, daily, often high-potency cannabis use, usually for years.
And the bathing?
The bathing in CHS tends to be more compulsive and provides significant, though temporary, relief during the attack. Patients might spend hours in the shower. In CVS, the hot bathing is more often a prodromal comfort measure.
And the definitive differentiator?
Resolution of symptoms upon complete cannabis cessation. Often it's quite dramatic improvement once they stop using. If someone's using cannabis daily and living in the shower during attacks, you have to strongly suspect CHS.
What about distinguishing it from abdominal migraine? They seem closely related.
They are, sharing that episodic nature and often headache overlap. But the defining feature of abdominal migraine is the severe abdominal pain being the primary dominating symptom. In CVS, it's the relentless vomiting itself that's the most prominent and incapacitating feature.
Okay, let's pivot to acute inpatient management. The patient is here, vomiting relentlessly. What are our first steps for stabilization?
Right. Rapid assessment, check vitals, hydration status, rule out those immediate red flags we just discussed, then get lab stat.
Which labs specifically?
CBC, definitely serum electrolytes, paying close attention to potassium and sodium, glucose, renal function, liver function, lipase.
Yeah.
A urinalysis gives you specific gravity for hydration, checks for ketones.
And if you suspect metabolic issues,
then you might need stat lactate, pyruvate, maybe urine porphyrins, depending on the clinical picture.
Now fluids, the guidelines are very specific here. It's not just any IV fluid, is it?
Absolutely not. This is a critical point. IV fluids are mandatory, yes, but they must be dextrose-containing solutions.
Dextrose-containing, why is that so important?
Because you're not just fixing dehydration and electrolyte problems, you're treating a profound energy deficit and actively preventing a catabolic crisis.
Explain that a bit more.
Okay, constant vomiting rapidly burns through the body's glycogen stores. The body then shifts into ketosis and starts breaking down muscle and fat for energy. That's catabolism. This metabolic stress state actually worsens the nausea and feeds the cyclic.
Okay. So the dextrose provides energy.
Exactly. By giving D5NS, or even D10 in kids or severely malnourished adults, you provide readily usable glucose. This stops the ketosis, halts the catabolism, provides energy for the brain, and helps break that vicious metabolic cycle. It's not optional, it's therapeutic.
And this needs to be combined with managing the environment, too.
Yes, supportive care is vital. Minimize sensory input. Dark, quiet room. Remember the photophobia and phonophobia of the migraine link? Reducing light, noise, Even strong smells helps calm that hyperexcitable nervous system, can actually reduce the amount of medication needed.
And acting early makes a big difference.
Huge difference. Early, aggressive intervention improves outcomes significantly, which leads us to the core treatment, multi-agent abortive therapy.
Multi-agent, not just one drug.
Rarely is one drug enough. Most patients need a combination, usually at least 2 different agents working on different pathways.
Given the migraine link, what about triptans?
Yes, triptans are well supported by moderate quality evidence. Sumatriptan is the usual choice, either 6 milligrams subcutaneous or the 20 milligram nasal spray. It's especially useful if the patient has prominent headache or clear migraine features. It hits those serotonin 1B, 1D receptors.
Okay, what's the first-line antiemetic then?
IV ondansetron, usually 8 milligrams. You can repeat it every 4 to 6 hours. But critically, ondansetron by itself often isn't enough.
So what do we add? What are the adjuncts?
You need drugs hitting different receptors. So think 5-E diphenhydramine, metoclopramide, or phenothiazines like promethazine or prochlorperazine. Sometimes these have to be given as rectal suppositories if the vomiting is too severe for IVs or pills.
And for the really tough refractory cases, we sometimes hear about needing a cocktail approach, focusing heavily on sedation.
That's exactly right. When the standard stuff isn't working, you have to escalate. One option is IV fosaprepitant. That's a neurokinin-1 receptor antagonist, usually a 150 milligram dose.
Targeting a different pathway.
Exactly. But often the key is breaking the cycle of anxiety, panic, and the physical act of retching through sedation. Deep rest is therapeutic here.
Which means using.
IV benzodiazepines. Lorazepam, typically 1 to 2 milligrams that P, or even sublingual alprazolam can work. The goal is to really sedate the patient, let their nervous system quiet down.
And if even that isn't enough?
For extreme agitation or truly unrelenting vomiting, you might need to consider sedating antipsychotics like droperidol or haloperidol. Usually this is done in consultation with specialists, but it highlights that we're treating a central neurological storm. Sedation is often the key to turning off that emetic generator.
Now let's talk pain. CVS is incredibly painful, but the guidelines strongly warn against opioids. This seems counterintuitive to some.
It is a major point of emphasis, and historically an area where management often went wrong. The AGA and ANMS guidelines are unequivocal. Opioids should not be first line for pain in acute CVS.
So what do we use?
The preferred non-narcotic analgesic is IV NSAIDs, specifically ketorolac. The standard approach is a 30 milligram IV loading dose,
Right.
then 15 milligrams every 6 hours, making sure not to exceed 60 milligrams per day and watching renal function.
Why does ketorolac work?
It targets the inflammation and prostaglandin pathways that get activated during that massive sympathetic surge that occurs in a CVS attack.
And why the strict avoidance of opioids? It's more than just addiction risk, right?
It is. The dependence risk is obviously a huge concern, especially in a recurrent condition, and it makes long-term management a nightmare. But physiologically, opioids often make the CVS worse.
How so?
They significantly delay gastric emptying. This increases nausea, bloating, and that feeling of fullness. They can also contribute to central sensitization, basically making the nervous system more sensitive to nausea signals. They feed the cyclic.
So our role as hospitalists is to actively resist using them first line.
Absolutely, we have to hold the line. Opioids are reserved only for the absolute most refractory pain, used with extreme caution for the shortest possible duration, and only after non-opioids have failed. Our job is to break the cycle, and opioids generally perpetuate it.
Okay, the patient's vomiting has stopped. They're starting to tolerate fluids. The inpatient stay is a golden opportunity to think about long-term prevention, about prophylaxis. When should we be initiating that?
Prophylaxis is definitely indicated for anyone with moderate to severe CVS.
And how is that defined?
Functionally, it usually means having 4 or more episodes a year, or having episodes that typically last longer than 2 days, or really any episode that's severe enough to require hospitalization.
And the goal of prophylaxis is?
Pretty straightforward. Extend that symptom-free period between attacks and reduce the frequency and severity of the attacks when they do happen.
What's considered the first-line agent, a go-to drug?
Unquestionably, it's tricyclic antidepressants, or TCAs, specifically amitriptyline. This has a strong recommendation for both adults and children.
How is it typically dosed?
You start low, really low, often just 10 or 25 milligrams at bedtime, and then titrate up slowly based on response and tolerance.
Why amitriptyline? What makes it work so well here?
It's acting as a central neuromodulator. It targets those brain pathways involved in CVS. But the bonus is it also treats the common comorbidities we talked about, migraine, anxiety, depression. It kind of hits the whole neurobiological picture.
That makes sense. Now, amitriptyline can have side effects, and some patients might not respond fully. Is there anything that improves its effectiveness?
Yes, and this is really important. Recent studies strongly show that lifestyle factors have a massive impact. Specifically, stopping opioids and stopping cannabis use significantly improves how well amitriptyline works.
So we need to counsel patients about that directly.
Absolutely. If they're continuing cannabis or opioids, they need to understand they are likely undermining the effectiveness of the best proven first-line prophylactic drug we have.
Okay, so what if amitriptyline fails, or the patient can't tolerate the side effects, the sedation, the dry mouth? What are the second-line options?
Then we usually turn to anticonvulsants. Topiramate is an option. It can be effective, but it's often limited by side effects, particularly cognitive issues that Dopamac's nickname isn't entirely undeserved. It can really impact adherence.
Other anticonvulsants.
Zonisamide and levetiracetam are also considered second-line options.
What about that newer class, the neurokinin-1 antagonists, like aprepitant? Is that used for prophylaxis?
Yes, aprepitant is emerging as a really important option, particularly for adults with severe refractory CVS who haven't responded to TCAs or anticonvulsants.
How does it work?
It targets the neurokinin-1 receptor, which is a key player in the central vomiting pathways involving substance. Studies have shown it can reduce episode frequency and healthcare use in these difficult-to-treat patients.
Are there barriers to using it?
The main ones currently are cost and sometimes insurance access, but for a truly disabled, refractory patient, it's a strong therapeutic avenue backed by growing evidence.
What about adjunctive therapies? Those mitochondrial supplements like CoQ10.
Right, coenzyme Q10 and riboflavin, which is vitamin B2. These are often used as add-ons, not usually as monotherapy.
Who might benefit most from those?
They're particularly considered in children or in any patient where there's a suspicion of underlying mitochondrial dysfunction, maybe suggested by family history of certain neurological issues. The idea is to help improve neuronal energy stability, making it harder for a trigger to set off an episode.
So we have the meds, but long-term success isn't just about pills, right? It requires that broader biopsychosocial approach.
Absolutely essential. Pharmacology is maybe only half the equation. Long-term care has to be multidisciplinary. Meaning incorporating non-pharmacologic strategies, aggressive stress reduction techniques, cognitive behavioral therapy perhaps, strict attention to regular sleep schedules, identifying and avoiding individual triggers, which requires careful history taking. Sometimes dietary changes, like avoiding tyramine-rich foods, similar to migraine management.
And managing those comorbidities we keep mentioning.
Crucial. You have to actively screen for and treat the anxiety, the depression, any underlying sleep disorders, or signs of autonomic dysfunction. If those aren't addressed, they will continue to fuel the CVS and make sustained recovery much harder. Treating the whole patient is key.
Okay, let's think about complications and prognosis. During the acute hospital stay, what are the immediate risks we need to monitor for?
Acutely, the big worries are severe dehydration, naturally, major electrolyte problems, especially low potassium or abnormal sodium, and that metabolic decompensation we discussed, the catabolic crisis, potential for lactic acidosis if things get really bad.
And physical injury from the vomiting itself.
Yes, the forceful, repeated retching can cause mucosal injury, like Mallory-Weiss tears in the esophagus. And severe dehydration can certainly lead to acute kidney injury.
What about the chronic long-term consequences if CVS isn't well controlled?
The most feared long-term complication is progression to what's called coalescent CVS.
Coalescent.
Meaning the symptom-free intervals disappear, the patient transitions into a state of near-constant nausea, maybe low-level vomiting, essentially chronic symptoms. This leads to profound disability, malnutrition.
And they're chronic issues.
Chronic esophagitis from acid exposure, dental erosion is common. And sadly, that high frequency of ED visits often leads down the path of dependence on opioids or cannabis, which, as we've discussed, creates a whole new set of problems. Preventing that dependence is a key goal of effective management.
It sounds like the prognosis differs quite a bit between kids and adults.
It really does. For kids, the prognosis is generally more favorable. More than half of pediatric patients eventually experience complete resolution of the vomiting episodes.
That's encouraging.
It is. But there's a caveat. We need to counsel families that even if the vomiting stops, the underlying predisposition might remain. About a quarter of those kids, maybe 26%, might later transition into developing classic migraine headaches as teenagers or young adults.
And what about the adults who are admitting and stabilizing? What does their long-term picture look like?
Unfortunately, Adult CVS tends to be much more persistent, often more debilitating. Studies suggest only a small minority, maybe around 19% or so, achieve complete lasting resolution.
So recurrence is the norm.
Recurrence risk is very high for adults, and that subset who develop those chronic coalescent symptoms. They require intensive, ongoing, multidisciplinary care. It really underscores why getting the discharge plan right is so critical.
Okay, perfect transition. Let's talk about that discharge plan. What are the absolute key components the hospitalist needs to ensure are in place before the patient leaves?
Right, first things first. Confirm stability. That means the acute vomiting has totally resolved. Electrolytes and any metabolic issues are corrected. Check that potassium and sodium again, and critically, they've demonstrated they can tolerate oral intake, usually starting with liquids and advancing, without triggering rebound vomiting.
Step 1. Ensure they're stable to go. Step 2.
Optimize the prophylaxis. Finalize the plan for their preventative medication, whether it's starting that low-dose amitriptyline or adjusting something else. You need clear counseling on the titration schedule, what side effects to expect, and hammer home the importance of sticking with it, adherence.
And empowering the patient to manage this at home seems vital. They need a roadmap.
They absolutely do. Every patient should leave with an individualized written action plan. Best practice, honestly, is using a pictographic CVS action plan.
Graphic, like with pictures.
Yeah, using clear graphics, maybe color coding. It details the exact steps they should take at the first sign of a prodrome or episode starting.
What should that plan include?
It needs to specify exactly when to use their home abortive meds. Things like sublinguals ondansetron, maybe a rectal promethazine suppository, or their home sumatriptan if prescribed. And just as importantly, clear, unambiguous instructions on when they must return to the emergency department.
Like specific red flags for return.
Exactly. For example, if their home abortive therapy doesn't work after, say, 2 hours, or if they can't keep down any liquids at all for 4 hours straight, concrete triggers for seeking immediate care.
And we need to circle back to those lifestyle issues, especially opioid and cannabis use.
Non-negotiable part of the discharge counseling. You have to strongly, clearly emphasize the need for cessation. Explain why that the data shows it's vital for improving their response to the prophylactic meds and their overall long-term outcome. Frame it as essential medical advice, not judgment.
And finally, follow-up.
Crucial. Arrange timely, structured outpatient follow-up, not just with GI, although that's important, but also ensuring connections are made with allied health, potentially behavioral health specialists, dietitians maybe, to ensure that ongoing multidisciplinary support.
This has been incredibly helpful, a really thorough deep dive into managing a condition that frankly can be baffling in the acute setting. So just to summarize the absolute key takeaways for hospitalists listening.
First, recognize CVS by its pattern. That stereotypic cyclic recurrence, using those Rome 4V criteria as your guide. Don't dismiss it as just another bout of vomiting.
Right. And second, the inpatient management strategy needs to be specific and proactive.
Absolutely. Mandatory dextrose-containing IV fluids. Don't forget the sugar to fight that catabolic state. Early, aggressive, multi-agent abortive therapy. Think triptans plus antiemetics plus benzodiazepine sedation.
And crucially, manage pain smartly.
Yes. First-line pain relief is ID ketorolac. Avoid opioids unless absolutely necessary, because they often perpetuate the cyclic.
It really drives home that the complex pathophysiology, that central autonomic neurohormonal dysregulation, means our treatment has to target the gut-brain axis itself, not just symptom control like dehydration.
Precisely. And that actually leads nicely into a final thought for our listeners to consider.
Yep.
For those patients who fail the standard prophylaxis, like amitriptyline, maybe they fail topiramate-2. We're seeing stronger evidence for agents that more directly target those central pathways. Specifically, think about the neurokinin-1 antagonists, like a perbetin.
For refractory adult CVS.
Exactly. The success of these agents really underscores that we need to treat CVS as the primary neurobiological disorder it is. It's not just a GI problem. Understanding how and when to use these central neuromodulators like aprepitant represents a significant step forward in managing this truly persistent and disabling condition.
That's a really compelling point about shifting our perspective and treatment focus for refractory cases. A fantastic clinical mandate. Thank you so much for walking us through the evidence on cyclic vomiting syndrome today.